It's a great pleasure to be here to try to follow on from the virology with some pharmacology. And I'm going to focus particularly on new delivery options, not only of integrase inhibitors, but a little bit of other classes as well. So some disclosures for both the websites that we run and personal disclosures. I want to go into 5 distinct areas. Here are the first 4, and then we'll summarize at the end. A little bit about the changing face of treatment, and then oral nanoformulations of antiretrovirals. Is there anything new about oral formulations? Then intramuscular long-acting formulations to follow on from some of the discussion that we had in the resistance session, and also long-acting implants of antiretrovirals. So I want to start with these 4 areas. And the changing face of treatment is something that I'm sure all of us know. How many people were at the very beginning of the HIV field, back in 1983 with the discovery, and then through the different periods with monotherapy to triple drug therapy, single tablet regimens, into the integrase era, which we've already been discussing, and then 3 specific topics there at 2018, and that is the new drugs which are in the pipeline, 2 drug regimens which will clearly be part of the discussions today and through this conference, and then thirdly, the new delivery systems which we have to at least discuss and to see where we are on the cascade of development of these new delivery systems. If you have an overview of the guidelines for the international field for first-line antiretroviral treatment, if you look at Europe and the USA and the World Health Organization for the guidelines, clearly common to all of those guidelines are the integrase inhibitors. And the integrase inhibitors, which you can see in the middle, for all of the guidelines. And then you have protease inhibitors in some, NNRTIs in some, and the backbone of the NRTIs. Now, interestingly, since the beginning of HIV, we've had 29 approved drugs. And now in the international guidelines, we come down to 11 drugs that are currently mentioned. Darunavir, Rilpivirine, Dolutegravir, Ibalizumab, Rilpivirine, efavirenz, and then 5 NRTIs. So from 29, we're down to 11 drugs as far as first-line antiretroviral treatment options are concerned. With the integrase inhibitors, we've already discussed a lot this morning, but they're not all the same, clearly. They're not the same in the doses that we use. So Rilpivirine, either 400 BD or 1200 once daily. And then Ibalizumab boosted, 150 boosted. Dolutegravir, 50 milligrams. Bictegravir, 50 milligrams. So the dosages are different. And this is in part due to the inherent properties of the molecule, but also the fact of how the drugs are being handled in the body. I'm going to talk tomorrow about drug-drug interactions, but you can see here that the highest drug interaction potential is clearly with a drug that is boosted with cobicistat, Ibalizumab, and the least drug interaction potential is with Rilpivirine, which is broken down in the bloodstream, in the liver by the enzyme UGT1A1. Dolutegravir has some cytochrome P450 related metabolism. Bictegravir is 50% as far as the 2 pathways of breakdown are concerned. And so that reflects then the potential for drug-drug interactions. If we look at the new pipeline as far as antiretroviral therapy is concerned, you can see that recently approved, we have Doravirine, which has only been approved in the last couple of weeks for the NNRTI. We have in the entry inhibitors Ibalizumab, which is a monoclonal antibody. And then, of course, Bictegravir, which we've already discussed. And then in phase 3 development, the other integrase inhibitor, Cabotegravir. And because I'm going to be talking about delivery systems, I also want to mention the MK8591, which is the NNRTI in early phase 1-2 development. And so we do have a pipeline. You know, people often say with hepatitis C that it's done, the pipeline is over. And that sometimes is also, is HIV pipeline finished? Well, clearly the HIV pipeline is not finished. We do have a number of drugs both in phase 3 and phase 2 and phase 1-2 development, which is exciting. Because I'm going to be talking about long-acting and different formulations, just a word about Ibalizumab, because this recently approved 2018 drug, which is for heavily treatment-experienced patients, is a drug administered intravenously with a loading dose followed by a maintenance dose every 2 weeks. So this is an intravenous administration of a drug which is clearly a longish acting drug. And that is something for a discrete small population of patients who are highly treatment experienced. And then one slide without any reference really, other than as we go down and look at the future, what is in the future, then 2 drug regimens and the kind of questions that will be addressed in this meeting and beyond around the 2 drug regimens. And clearly Pedro has been the real leader in this field. So I want to now talk and say, is there anything happening as far as oral formulations of drugs are concerned? Is there any developments in this particular field? And there are a number of organizations, and reflected at the bottom of this slide is USAID and PEPFAR and various academic institutions and generic companies who are coming together to try to say, can we improve the drugs that we already have? And so nanoformulations is a topic which is discussed a lot at the present time. Many different types of technologies of drug delivery. Without going into any details about these drug delivery processes, it is really to try to improve the way that we can give drugs, maybe at lower doses, maybe for longer acting. And so we have a lot of different nanotechnologies which are being used to explore drug delivery. Now, I just want to give you one example of oral nanoformulations. Many drugs are really difficult to dissolve. So in the slide where the hand is showing, that's a typical antiretroviral, which in water is very hard to dissolve. But the one on the other side, you can gradually see now that the nanoformulation, which is a different type of formulation of the drug, is now easily dissolved in water. So that means you have a better chance of being able to lower the dose of the drug and get a formulation of the drug. One example could be for pediatrics. So currently, for example, in pediatric Kaletra, every ml of pediatric Kaletra, which contains Rilpivirine and Ritonavir, has 42% of alcohol. So for a pediatric preparation, you have a lot of alcohol and you have a lot of propylene glycol, which clearly is not a good thing for an infant to be having. So if you can improve pediatric formulations with nano-oral formulations, that is obviously a very good thing. And also to reduce costs because you have less of the active pharmaceutical ingredient. Now, we've been working on a paradigm of trying to lower the doses of drugs. And we started with Rilpivirine and efavirenz in the team in Liverpool. And it is estimated that if you simply reduce the dose of drugs like efavirenz, and this was rolled out, then the potential cost saving would be $250 million per year based on the current usage. Now, there is a study ongoing, and this may be hard to see at the back, but there's a current clinical trial which is comparing 600 milligrams of efavirenz standard Sustiva with 50 milligrams of nanoefavirenz, 200 milligrams of nanoefavirenz, and 300, so lower doses of these nanoformulations. And the same with lopinavir, to remove ritonavir, rather than have boosting of a protease inhibitor, to have lopinavir without any boosting in order to try to overcome some of the drug interaction issues. So this is one area of development. And if this can be proved clinically to work, it could go on to other areas of antiretrovirals. Finally, on the oral drug delivery system, this is quite an exciting area for development. And here we have the development of a once-weekly delivery system for oral administration. Now, it looks complex, but actually this device, and I'm sorry that the pointer doesn't work, but this device is simply a capsule which, when it is swallowed, comes into 6 arms. So the capsule is swollen, is taken whole, and then it goes into 6 arms once it's in the stomach. So here you can see the stomach, and once it's in the stomach, you have the 6 arms, and each of those arms contains drug. So currently, this device is being used with dolutegravir, Cabotegravir, and Rilpivirine in different formulations in the different arms. And does it look huge? Well, it's only 3 millimeters across. So the maximum size when you look across is 3 millimeters for each arm, containing drug. And the drug concentration, I'll give up with the pointer. If anyone has a pointer, it'd be fantastic. But if you can see, then each of those arms actually has the drug in, and the drug is then able to be dissolved out of the formulation. So I think it's a really exciting area. It's only been used so far in animal studies, but it will then hopefully go into clinical trials later. So that's the oral area. Now let's look at the intramuscular, long-acting nanoformulations of antiretrovirals. A definition, I think, is important for us, because what do we mean by long-acting? It's a drug with a prolonged effect because of the formulation, resulting in the release of the active drug or the continued absorption of the drug over an extended time, so that we have a long-acting drug from a single administration of the drug. Now, what is the attraction of the long-acting? We touched on some of the negative aspects potentially before. Some of the attractions that are highlighted are the infrequent dosing, the lower overall drug dose that can be used. Does it prevent poor adherence? And that's a discussion that we started, and maybe we need to continue around the poor adherence issue. The use in patients with pill fatigue, potential of directly observed therapy, and then does the drug target tissues? Can we get the drug to target tissues? Does it better protect health privacy and treatment-related stigma? These are some of the points that are raised about the attraction of long-acting drugs. And there's a huge literature. Just look at the 2018 literature, reviews about long-acting, treatment and prevention with long-acting antiretrovirals, Rilpivirine as a drug which is discussed, nanoformulated dolutegravir, and also other formulations as well. Here is Maraviroc. So there's a lot of literature and a lot of interest around the long-acting field. But the preparation that has clearly taken most interest from the intramuscular point of view is the integrase inhibitor Cabotegravir with the NNRTI Rilpivirine. We know from oral data that those two drugs have matched half-lives, in that the oral half-life for Cabotegravir is around 40 hours, and for Rilpivirine is around 50 hours. So here you have two drugs which have got similar half-lives. You then take those two drugs into a long-acting formulation, and the half-life of the long-acting Cabotegravir is 20 to 40 days, and the half-life of long-acting Rilpivirine is 30 to 90 days. So you do have matched half-lives or nearly matched half-lives for the long-acting drugs. We know, and we touched on it before, we have data from the oral formulation with LATE-1, and then the 96-week data from LATE-2, which was published at the end of 2017. Remember that in LATE-2, the details of LATE-2, the phase 2b study, patients were started on the oral formulation of Cabotegravir plus Abacavir 3TC, and then into 3 arms were randomized to continue Cabotegravir, Abacavir 3TC, or to go in an arm which was 8 weekly of the intramuscular or 4 weekly of the intramuscular, with the objective to look at clearly the percentage below 50 copies at week 32 of the maintenance dose, but taking it out beyond to week 48 and week 96. And the snapshot data at week 96, if you compare the 8-week and the 4-week and the oral formulation, is that we are able to see that the data for the week 48, which is the funny hatched bars, and the week 96, which is the solid bars, there seemed to be a slightly percentage-wise definite result for the 4-week versus the 8-week, and you've got the difference there, which is shown. So non-inferiority of the 2 intramuscular regimens, lower performance of the 4-week versus the 8-week at week 96 due to more discontinuations. And so that is important. Now, interestingly, it was the 4-week which was taken forward, and this is the recent press release on August the 15th of this year for the phase 3 data in 600 plus patients of the pivotal data for this long-acting combination of Cabotegravir plus Rilpivirine. So it's an exciting area to have these 2 drugs which are matched as far as pharmacokinetics are concerned, and where we have both phase 2b and now phase 3 data going forward. Very interestingly, in the LATE-2 study, the patient-reported outcomes at week 96 were also very interesting to see, that the pink bars, which is the very satisfied. So you have very satisfied to the question, how satisfied are you with the current treatment? Then you can see that every 4 weeks, 76%, but even more satisfied if it was every 8 weeks, it was 85%. And then the second question, how satisfied would you be to continue with that treatment every 4 weeks or every 8 weeks versus oral pills? And it was 88%, 89% versus 43% for the oral pills. So it's very interesting in the questions from LATE-2, but it was a relatively small study, of course, in LATE-2 for a selected group of subjects. The pharmacokinetics are interesting, and just one study, or one slide to show the pharmacokinetics. With the long-acting, you're trying to get the pharmacokinetics, the blood levels of the drugs, similar to what we get from the oral administration of the drugs. And the oral administration is the black line that goes across, and the Rilpivirine data is in the blue, the Cabotegravir is in the green, and you can see the blood levels from the 4-week and the 8-week. There's more troughs if you have the 8-week versus the 4 weeks. But you can see the data is pretty close to the oral formulation of the drug out to 48 weeks in this slide. So, some of the issues which we might want to discuss a little bit more is, can we go beyond Cabotegravir and Rilpivirine? Which drugs are going to be combined in these long-acting forms? The injection volume and the site reactions to the injection, and the whole issue about missed doses and long-term low drug concentrations at the end of a dosing interval. And do you want highly adherent patients or less adherent patients? I think there's more discussion. And the need for an oral lead-in, how long is that oral lead-in going to be, and are drug interactions going to be different, and how do you plan to study drug interactions with long-acting preparations? These are all interesting. Just one point about the long tail. We did a study in conjunction with Professor Ian McGowan in Pittsburgh around the issue of rilpivirine and the tail of rilpivirine. We had one group of healthy volunteers in one study, and then we moved after a year or so to a separate study, and some of the subjects were included in both studies. And when we came after a year to analyze at baseline whether there was any rilpivirine in those subjects, we found that there were rilpivirine concentrations. So although it's, again, I can't point out the data, what you have is concentrations at the end of this graph of 8 nanograms per mil 400 days after they'd stopped the previous single dose of rilpivirine. So over a year after stopping, you could still see rilpivirine concentrations, which are only just below the IC90 for rilpivirine. So rilpivirine certainly stays in the bloodstream. And there were some subjects there up to 800 days, so that's nearly 3 years, 2.5 years, there was still rilpivirine present in the bloodstream. So clearly this is something that we have to think about. And we have to think about it in terms of one patient that was in a study that we did in the UK called the SSAT 040 study. This was a study in PrEP, and these were healthy volunteers where we were having different doses of rilpivirine, 300, 600, 1200 rilpivirine. And the blue line is the rilpivirine concentrations. But here in this healthy volunteer study, there was one subject who had an exposure to a new partner who was HIV positive, and the blood concentration had just fallen below the IC90. The green line shows the rise in viral load in this subject. So there was virus there and a high viral load. We initiated antiretroviral therapy, but there was the emergence of the K101E in this subject. And so this was a healthy volunteer, new exposure, you could see the viral load, and you had the K101E. So it is an issue that we really do have to tackle about the tail and about subjects missing doses of long-acting. And also, how are we going to do drug interactions? Because there's a difference between an oral formulation of a drug, which clearly is absorbed from the GI tract, through the GI tract into the portal circulation and goes to the liver, versus a long-acting form which goes directly into the systemic circulation. And trying to understand drug interactions and whether you would do a drug interaction with a long-acting preparation, we think that modeling using a system called PBPK modeling, physiological-based PK modeling, is probably the best way to understand drug interactions. And this was a study we had at CROI this year, where looking at rilpivirine and Cabotegravir with rifampicin, then we were able to predict the magnitude of the rifampicin interaction with the long-acting form based on our understanding of what rifampicin does to the oral formulation of Cabotegravir and rilpivirine. And so this might be the best way forward to understand long-acting drug-drug interactions. And then finally on this point, just to make the total load of drug that a subject is going to be taken. If somebody takes dolutegravir, abacavir, 3TC, and they take a daily dose of 50, 600, 300, then they're having yearly drug of 346 grams, which if they take it, this is hypothetical, for 50 years, they're taking 17 kilograms of drug. But if you have Cabotegravir rilpivirine intramuscular every 8 weeks, then you're taking over 50 years only 300 grams of drug. So 17 kilograms versus 300 grams of drug. maybe in terms of overall amount of drug in the body, there is an advantage of having less drug. Finally, just a word about long-acting implants of antiretrovirals, because this clearly is an exciting area. We use implants. This is Chad, Democratic Republic of Congo. Over 50% of women, their contraceptive form is implants, and also long-acting intramuscular injections in the red zone as well. So a lot of women are used to taking these kind of preparations. So we have exciting data emerging with long-acting implants, an implant which is a rod or a different type of device, which has potential advantages over the injectables because you can remove the rod or you could remove the device, and it gives you consistent drug release, could remain in place for 1, 2, 3, maybe longer years. There are clearly some disadvantages as well. The device required to insert it, a little surgical procedure, the removal, is that easy? And it's regulated as far as regulations are concerned as both a drug and a device. The most exciting data probably is with the MK-8591, which is this highly potent long-acting agent. It's a nucleoside reverse transcription translocation inhibitor, very potent as far as antiviral activity is concerned, with a long half-life of the active triphosphate. It's a nucleoside, so it's got an active triphosphate. The initial data was with oral form, 10 milligrams, single dose, giving a drop-in viral load of 1.7 log. That was a single dose, just giving that log drop over 10 days. And then the dose has even gone down from 10 milligrams to 0.5 milligrams, suppressing HIV for at least 7 days. So 0.5 milligrams compared to some of the dosages that we're using of the antiretrovirals. And then the data is emerging in animals, so this is non-human primates on that side, showing the long time that the drug stays in the bloodstream as the triphosphate, so greater than 180 days extended release after a single injection. And then this is data just released in the last couple of weeks of the extended duration of different types of implants in non-human primates. And the data really shows out to 120 days after an implant of the MK-8591 that the drug levels stay for this half a year. And it may be able that we can go well beyond that. The final slide is this is a new type of device of microneedles or microarray patches. It's a patch which can go on the arm, and although it looks not very nice, it has these really tiny, tiny needles, and those needles contain the drug, and the drug is dissolved out of the needles and gets into the subcutaneous and then into the bloodstream. So it's like a skin patch which is worn and continuously releases drug. And there's going to be developments in this area. And again, from CROI this year, we had a study to show that effective dose and release of Cabotegravir, Integrase, and Rilpivirine could be an exciting way forward. And we use this PBPK modeling to show that. And you can work out the size of the patch that would be needed to give you enough drug to last for 3 months, 6 months, or a year or beyond. This might well go into other diseases, these long-acting forms for tuberculosis, for hepatitis, for malaria, maybe even for Ebola. And there's clearly a whole field of long-acting chemistry and long-acting pharmacology and clinical studies which is necessary. So thank you very much. I hope there's something of interest there for this exciting field.